Good morning, dear students. We want to learn some approaches, mainly word-based and also exam-based. But our focus should be on how we recognize the emergency signs in the ward settings and can help to prevent any catastrophic event. So, the first symptom analysis we can start with the chest pain. In any time, I always ask my students to determine if we are in a state to take the detailed history or not, and what are the signs that tells us that we can wait or we cannot wait. These are some red flag signs. In case of chest pain, if the patient has abnormal vitals, the patient has collapsed, that we commonly call syncope, the patient has blood pressure asymmetry in both side hands or pulse asymmetry, the patient has hemoptysis, severe shortness of breath. These are the signs that we cannot wait to take a detailed history. Rather, immediate resuscitation and history taking should go in hands. First of all, if the patient is hypoxic and having respiratory distress, we must give the patient oxygen. In case of bilateral vasoconstriction and we are suspecting heart failure, we must give the patient diuretics, bed rest in propped position, and then detailed history taking either from the patient or from the family members. So, is these red flag signs telling us something? Definitely. These red flag signs are telling us these may not be a cause of non-cardiac chest pain. So, in case of chest pain, the first approach is to determine if this is an emergency. We need to do the resuscitation first, and second, is this a cardiac or non-cardiac chest pain? There are some common clues by which we can determine if it is a cardiac or non-cardiac chest pain. The cardiac chest pain is usually central, constricting, crushing, and more severe in intensity. And the peripheral chest pains are either right-sided or left-sided. They are more marked, increased during deep inspiration, or they may increase after movement, and on severity scale they are much less severe, and they will give you time to take the detailed history. But in case of cardiac chest pain, you can rarely have the time. So the cardiac chest pain are again divided into some common types. What we encounter most commonly in the ward is acute myocardial infarction and angina. Now there are two types of angina. One is stable angina, one is unstable angina. Stable angina less commonly presents to the ward. These are the patients who have respiratory distress or have limitation of their activities after activity. But these pain usually relieves within 5 minutes of resting or taking the GTL spray. So stable angina is also a cardiac pain that is central, that may be constricting or squeezing in nature, that may relate to the jaw, arm and left upper arm. But these are 2 or 3 signs that tell us that it is not acute coronary syndrome. And these signs are pain relieved within 5 minutes of rest or taking the GTN, and the patient has no autonomic symptoms such as vomiting, nausea, bradycardia or tachycardia. The patient has no fear of impending death. Okay, so these are the signs of stable angina. In case of unstable angina or acute myocardial infarction, we encompass these two under one single heading, that is called acute coronary syndrome. So acute coronary syndrome has two determinants. One is unstable angina and one is acute myocardial infarction. Regarding unstable angina, it is more or less likely that is stable angina. One differentiating dangerous point is the pain is relentlessly progressive and does not relieve after taking rest or GTN spray. And acute myocardial infarction, this also presents with central, crushing, constricting chest pain associated with the fear of death, that is called Engord enemy, and there may be some autonomic features. These autonomic features may be a sign that inferior myocardial infarction should be suspected, such as bradycardia, vagal signs such as vomiting, nausea, etc. And the pain is not relieved even after rest or GTN spray. So how can you differentiate between the unstable angina and the acute myocardial infarction? Both of the things are same, but if there is evidence of myocardial ischemia or infarction, that evidence may be dynamic ECG changes or cardiac biomarker troponins may be raised. There may be echo evidence of new regional wall motion abnormality. These may indicate that this part of the myocardial cells are not vibrating as they should, means these are dead cells or necrosed cells. And if we are doing any coronary angiogram and find out there is stenosis or plaque in this area. So if we have any of these evidence of direct myocardial ischemia or necrosis, we call it myocardial infarction. And if there is pain and associated features of myocardial ischemia, but in the absence of any evidence of myocardial ischemia or necrosis, call this unstable angina. Clinically at the bedside, we are having any patient who presents with a central chest pain, squeezing in nature, having autonomic symptoms, we should at first go for ECG and look for any changes. So always the patients with acute MI present with ECG changes. Commonly they should present with some kind of ECG changes, but they may not be always typical ST elevated MI. So there may be some subtle changes as well. The patient can present with arrhythmia. The patient can present with new onset left bundle branch block. There may be T inversion. There may be ST elevation. So whenever in doubt, we are doing the ECG. If typical symptoms are present, we are giving the loading dose and then sending the cardiac biomarkers, that is troponin I. These raised evidences tell us if this is a case of unstable angina or this is a case of acute MI. Sometimes after having the initial ECG normal, it is advised to repeat the serial ECG. So we can see the dynamic changes that may not be present in the first ECG but appears later, giving the loading dose and sending cardiac troponin biomarkers. If these biomarkers in hand suggest that yes, there is direct evidence of myocardial ischemia, then it is a case of acute myocardial infarction. If this says no, there is some kind of myocardial ischemic pain, but there is no evidence of clinical evidence of myocardial ischemia or infarction, then we treat the case as unstable angina.